Welcome to Anatomy Masterclass of the GIT System. We'll explore the structure, blood supply, histology, and clinical aspects of the gastrointestinal tract step by step. The gastrointestinal tract, also called the alimentary canal, is a continuous muscular tube. It starts at the mouth, passes through the pharynx, esophagus, stomach, small intestine, large intestine, and ends at the anus. The average length is 7 to 9 meters in adults, divided into foregut, midgut, and hindgut embryonically and according to the vascular supply. The digestive tract wall has 4 layers, remembered as MSMS. Mucosa serve for absorption, secretion. Submucosa contains Meissner's plexus and responsible of secretions. Muscularis externa gives strength for peristalsis, controlled by Auerbach's plexus. Serosa or adventitia, depending on location. Ulcers penetrate beyond the mucosa, while erosions remain superficial. Now let's discuss the important anatomical points of the gastrointestinal system. The esophagus has normal constrictions at the cricoid cartilage. Aortic arch, left main bronchus, and diaphragm. The stomach connects at the gastroesophageal junction, followed by the duodenum in a C-shaped loop around the pancreas. Esophagus contains non-keratinized stratified squamous epithelium throughout it, is divided into 3 parts. Upper 1/3 have skeletal muscle in muscularis layer. Middle 1/3 is transition zone, have mixed skeletal and smooth muscles in muscularis. And lower 1/3 have smooth muscle in muscularis. Stomach have simple columnar epithelium. Gastric pits and glands. Parietal and chief cells. Jejunum have abundant villi and plicae circulares, and no Brunner's glands. Ileum important for immunity, and have Peyer's patches in lamina propria. Colon have abundant goblet cells, no villi. The small intestine absorbs nutrients with jejunum specialized for absorption and ileum containing Peyer's patches. The large intestine reabsorbs water with Tanii coli and haustra as external landmarks. Some abdominal structures lie behind the peritoneum. These are the retroperitoneal structures. Remember them with the mnemonic SADPUCKER. These structures include suprarenal glands, aorta and IVC, duodenum, 2nd to 4th parts, pancreas, except the tail, ureters, colon, ascending and descending, kidneys, esophagus, thoracic portion, rectum, partially. Clinically, it is important to remember because injuries here may cause blood or gas to collect in the retroperitoneal space. The gastrointestinal tract drains primarily into the portal venous system, which explains why cancers of the gut often spread first to the liver. At certain sites, however, the portal and systemic circulations are directly connected through portosystemic anastomoses. The 3 most important sites are esophagus, where dilation leads to esophageal varices, a life-threatening cause of upper GI bleeding. Umbilicus, where engorged veins radiate outwards, forming the classic caput medusae. Rectum, where congestion contributes to hemorrhoids. In portal hypertension, these anastomoses become markedly dilated and symptomatic. Management may include transjugular intrahepatic portosystemic shunt, which creates a channel between the portal vein and hepatic vein. While this relieves portal pressure and reduces complications, it can also shunt toxins into systemic circulation, sometimes precipitating hepatic encephalopathy. The liver is arranged into hexagonal lobules, each with a central vein in the middle and portal triads at each corner. Blood from the portal vein and hepatic artery flows through the sinusoids toward the central vein. Within these sinusoids, specialized cells play key roles like Kupffer cells act as macrophages, clearing pathogens and debris. Ito cells store vitamin A, but when activated, they promote fibrosis and cirrhosis. The lobule is divided into 3 zones of vulnerability. Zone 1 is periportal and closest to incoming blood, and first affected in viral hepatitis. Zone 2 is intermediate and classically injured in yellow fever. Zone 3 is centrilobular and most hypoxic, making it highly sensitive to ischemia, toxins, and alcoholic hepatitis. Bile produced by hepatocytes flows into the biliary system and stored in gallbladder. The gallbladder releases bile on demand into duodenum through bile duct. Obstruction at the ampulla of water by gallstones may cause cholangitis or acute pancreatitis. Alternatively, a tumor in the head of the pancreas can compress the bile duct, producing painless obstructive jaundice. A palpable, non-tender gallbladder in this setting is known as Courvoisier's sign, a classic marker of malignancy rather than gallstones. The gastrointestinal tract is a highly specialized system for digestion, absorption, and excretion. A clear understanding of its anatomy, blood supply, histology, and clinical correlations is essential for medical practice. In our next episode, we'll explore the physiology of the GIT system, covering the all hormones play a key role in maintaining digestion, absorption, and secretion. Don't forget to like, share, and subscribe to MedPro Education, bringing you simplified medical learning, one concept at a time,